Okay, so welcome to the supportive care track, and I'm Dr. Jimmy Ellis, and in keeping with protocol, when you give someone's bio, you have to say where they're from, and if they're from New Orleans, neighborhood and high school. So I'm from Old Jefferson, and I went to Rummel High School. I'm an LSU predominantly trained hematologist oncologist. I did some of my fellowship training at Wake Forest University. In addition to hematology and oncology, I'm also a palliative care physician, and I currently work for Turo. We're going to touch on 3 distinct supportive care topics today, and in my talk I'm going to connect those dots and show you how these work together to provide holistic care of the cancer patient. I'm also going to take a little time to talk about the CAGLA process. You've heard Chad talk about how we've passed 10 laws over the last 4 years. Every one of those laws at some point in time was an unmet need or a problem. How we get from that to legislation, we're going to go ahead and go into. So we're going to start off with physical therapy for the cancer patient. Dr. Troy Bourgeois is our speaker. In keeping with protocol, he's from kind of Metairie, River Ridge, went to De La Salle. We had the same high school calculus teacher. So New Orleans is a small town. He's a doctor of physical therapy, the founder of the Movement Science Center. He went to Christian Brothers University in Memphis, got his master's degree from the University in Physical Therapy from University of Tennessee, Chattanooga, and his doctorate in Rocky Mountain University. And Troy, go ahead and take it away.
Thank you so much, Dr. Ellis, and thanks for clearing that up and understanding that when you're from New Orleans, we do have to just completely make sure we all knew where we all grew up and how we're all completely connected. It's the one most fascinating thing about being in the New Orleans metropolitan area. It's the thing I missed most. You know, I moved away for college, grad school, residency for about 10 years, and it's so amazing when you come back home and the first thing people are doing is figuring out a way how we're all connected and how we're just one person removed from each other. It's a beautiful, beautiful thing. So, like you said, I mean, supportive care is such an important piece to the puzzle for our patients. And one of the things that's been, you know, kind of sad for me over my career is watching how little importance had been put in physical therapy and rehab when it comes to patients struggling with, fighting with cancer, recovering from the fight. And you see the simplicity in the way we think about rehabilitation and recovery. I mean, we get somebody that sprains their ankle, and they're going to get months of therapy to make sure they're jumping as high as they ever did. They're running as fast, right? You think about, you know, the type of surgeries we deal with in sports medicine, and you think about it comparative to a cancer patient, right? You get a patient goes into surgery, and they get a little ligament, you know, reconstructed in a procedure that takes, you know, 45 minutes. And that patient's going to get every month of recovery time and rehabilitation to make sure that patient, not only is that ligament completely restored, but every single muscle and tendon that could have had some loss of perfect function in that surgery that took 45 minutes and was done, that patient's going to have 6 months down the line and make sure that they've got every bit of function necessary when they're finished. And so we live in a society where we've put a lot of importance into that orthopedic and sports medicine world. The physicians in that world know that if the patient doesn't rehabilitate properly, that the body's tissue doesn't remodel properly, and if that doesn't happen, those outcomes aren't going to be the same. So they put tremendous importance in it. It's a big, big, big focus. And then I've got my patients struggling with cancer. And those patients have incisions and wounds that go from one hip to the other. Those patients have months and months and months of dealing with chemotherapy and radiation, and their surgeries are so much more invasive. Their treatments are so much more difficult, and their struggle to get back to any form of function is, and these patients are so wonderful, and they're so grateful for their doctors that are saving their lives and the nurses that are caring for them, that, you know, I didn't want to bother them with the fact that I can't go from sit to stand without a sharp pain. You know, I'm alive, I should be thankful, right? And it's like, yeah, you should be thankful, but we as a community should also have putting the importance of your ability to get back to the things you love and the life you were living and the ability to live with your family in the same regard as we put with someone who sprains an ankle, right? And so I think our perspective is wrong. And I think that because of that, we have issues. We have issues with dealing with insurance companies because, insurance companies want to see improvement. They want to see constant recovery and improvement. And if they don't see that improvement, they don't want to pay for it, right? Well, how you got a patient and they're in the middle of radiation and chemo, right? Well, you're going to see significant strength gains, right? You're going to see it's unfair. It's not real. That's not what we can do with some of these patients during, in the middle of their care, or afterwards. It's going to take them a little bit longer, and so CAGLA and the importance of what we're doing here and the conversations that are being started here and pushed further are so important because, there needs to be a voice, and we're going to have to force the industry to change. We need to give patients a better voice. We need to have them understanding that their doctors and their nurses do want to hear about their limitations, and they want to take those seriously, and they want to get them the right care they need to get back to the functional life that they once lived and optimize this life that they fought so hard to survive for. And so, hats off to all the people saving the lives, right? But making sure that patient lives a happy and healthy life and optimizing their life, I think, is this next piece. Right. And I'm grateful that I get to be a part of that conversation. So, yes, I'm a physical therapist. Yes, we treat patients actively with cancer and patients that have had cancer. The first thing that we deal with when patients come into our office is there's this illusion, not backed by evidence, that if I exercise, if I move too much, the cancer is going to spread. It's going to go all over my body. I'm going to die faster. That type of fear is real for patients because they don't know. They don't know that that's not true. They don't know the story. And that's not something that they typically are getting when it comes to knowledge. Everything in the first focus of care is how to save someone's life. And so how they live their life while they're in that process can sometimes be second fiddle, right? I always feel like anything I'm doing with these patients is like I'm the redheaded stepchild, right? Like, kind of left out, left behind. Where is this importance? Well, I think we all have a pretty significant importance of our ability to function and live our life and to be able to go places with our family and be part of our family and friendship groups and part of our communities. And so that's what I'm going to argue is the real importance. So first important piece is, scream this from the rooftops, exercise is safe. It's wonderful. We have great data supporting that's affecting and reducing these patients' fatigue. And it's effective in improving their aerobic capacity. The next piece is exercise can reduce patient side effects. We all know what we feel like when we're lethargic, when we've sat for too long, laid around for too long, right? There's a change that occurs in our cellular metabolism, and it's something that changes our physical, the way we feel, but it also our mental capacity and the way we think and our moods. And so to understand that it's important to, any chance you get, reduce the side effect of someone going through fighting cancer. It can reduce the risk of cancer-related mortality. Specific studies that we were looking at here from the American Physical Therapy Association related to breast cancer and colorectal cancer, which clearly, obviously, are some of the most significant numbers in patients with cancer. Significant decrease in cancer-related mortality with daily exercise at a moderate intensity. So this isn't telling our patients, that you've got to go crush it and run a marathon. We're not telling our patients that you have to lift thousands of pounds and get into a strongman competition, but we're teaching them what moderate exercise is like. And I'll give you an example for patients that I've had kind of this week. I have a guy and he's dealing with the combination of chemo and radiation right now. And he just doesn't know where to start, right? He doesn't know. He knows that after he gets certain treatment that it takes him more than a day to recover from that and he's out. He knows that when he starts to come out of that before he's getting ready for the next one, that there's some sweet spots and some good days that he feels good, but he just doesn't know what to do, right? He doesn't know what to do. So in our conversation, it's how do I help him maintain muscle mass so he doesn't have too much wasting? How do I keep him able to have some endurance to fight the next battle? So what we look at is we talk to him about where his heart rate should be. What is his rate of perceived exertion? He's got a fancy watch. It's connected to a phone. We show him what that data means. We show him how he can analyze himself in sleep patterns and what kind of ability he should have that day and kind of how far he should push himself. That gives him comfort, right? He now has parameters. We do strength training to keep his muscle mass alive. We use major combination muscle groups. So we know he can't be in the gym lifting weights and doing that kind of stuff for an hour. He doesn't have it in him. But if I can use total body movements under load, I can maintain a certain amount of his body mass. And by doing that, he has a completely different experience. We're also dealing with everything else you could imagine. I mean, just this week, I've had a patient did not sit to stand. I mean, that's a legit thing. She couldn't go from sit to stand because after the breast reconstruction work was done and the surgical site was completely pelvis to pelvis, there was a section of it that had kind of scarred into her abdominal musculature, and it was so sticky and so thick that she couldn't fully extend. So she just kind of started to walk like this and stopped in full extension. Well, that meant she couldn't play the sports she liked, and it meant she was scared every time she went from sit to stand. Now, this is a mom, soon-to-be grandmother, and if you could imagine the things she's not doing with her family, vacation, simple activities, sports and recreation she used to do with her husband and some of her friends, all because of one thing. In a matter of 2 to 3 visits, this week she told me no more of that pain is there when she goes from sit to stand, and that's honestly, I think, her third visit. But in some scar tissue work, some dry needling lift under the scar, some cross-friction massage, some basic movement patterns of teaching her how to become more flexible in what she can do every so many hours, a little bit of strength training combined with that. In a matter of a couple of weeks, she doesn't go from sit to stand in any kind of pain, and she's starting to transition back into recreational activities, right? In 2 weeks, we took somebody that was dysfunctional for 6 to 8 months, right? And it's kind of like, how is that not important, right? How is that not a priority? But I digress. How do we begin? All right, how do we start? Well, we start with a physical therapy examination, and our examinations are all related to function. It's form and function of the human body. So a selective functional movement assessment, which is the next box, is we take a look at the human body and how it moves from head to toe. Make sure I got a good time. So we start with the cervical spine. We work our way from the head and neck all the way down to the toes. We look at every way the body is meant to functionally move, right? Within that, we categorize those movement strategies as functional and non-painful, functional painful, dysfunctional non-painful, dysfunctional painful. And those categories of movements take us into a pattern of studying that person's body to define where are those disorders coming from. A tissue extensibility disorder could be a muscle or tendon that doesn't move as well anymore, and so it lost its expandability, and that's changed the body's ability to move through a functional movement pattern. It can be a joint capsular limitation that changes the body's ability to move through a pattern. It can be a motor control issue where the nervous system and the muscular system aren't speaking correctly and don't know how to turn on to get the power back into that movement. We know how to tease those things out and to determine what step is next in that person's immediate recovery. So this isn't the old versions of, here's a protocol, here's some exercises, just go do them, right? It's more of defining what is the exact problem so we can fix that, and then you've got healthy, energetic tissue that can function. Now go do these specific things, plus do all the regular general things. And we always really are very specific at trying to in an effort to engage a patient and initiate them back into function is what have you ever done in the past that you loved in terms of human movement, physical activity, or exercise? Usually you're going to find this one thing that they really enjoyed, and that's the first step back into exercise and movement, is plugging them right back in there, and then just adding a few of those specialty pieces that you now know they need to add on top of that. But finding a healthy habit, defining that habit, getting back used to that, having a time and a space where you're going to move, and you're going to move well, and you're going to work on that, is kind of the time to put that in place. So that vestibular testing, these patients can really get, have their balance affected, their motor control, specific testing for the areas that are involved in the act of cancer, where the tumors were removed, incision sites, lymphedema management, et cetera. The cognitive deficits, the absolute beatdown, the ability to follow instructions using verbal cues, tactile cues, videos, home exercise programs with pictures and directions and apps. Our company has an app for us. The Movement Science Center app is what our patients get. And that allows them to have a video series and a coach at home coaching them through the movement, and the patient can study and watch the movement on video and then go through it with the coach, and they get to ask questions on that and stay kind of involved, because what we like to explain to patients is that what we do in a therapy clinic is really just kind of setting it and beginning it and starting the process of healing. What we do to challenge that human tissue all day long, every 2 to 3 hours, is what's going to affect how collagen is going to remodel and how that tissue is going to perform. Cancer patient, you deal with I got beat up so bad, I'm so much thinner, I lost so much. How am I ever going to, be anywhere close to the same? One of the most amazing things about the musculoskeletal system, not to brag since that's, my favorite system, but every 10 to 16 months, that system rejuvenates itself. It builds a new one, and it builds a new one based on the stress and strain that we provide it over that 10 to 16 months. So the thing that patients don't understand as they age, I'm 75 years old. How can I grow new muscle? Well, I'll tell you how you can't grow new muscle. You can't grow new muscle if you want your bicep to be stronger so you can pick up your dog food, and you don't do any bicep work under load that challenges that bicep to grow. Well, how are you going to get stronger, right? So the clarity is this most simple conversations that need to be had with patients that have been struggling with cancer and have had all this muscle atrophy is, in the next 10 to 16 months, you're going to grow some serious brand new muscles, right? And what we do in the next 10 to 16 months is what matters. And so that's the typical focus. Like I said before, explaining to the patient, vitals, where their heart rate, blood pressure, oxygen saturation, giving them basic parameters. So easy now. Like with the fancy watches, and now that every CVS and Walgreens has a pulse oximeter. So aerobic exercises have been studied. In this population, typically something as easy as 10 to 20 minutes of aerobic exercise daily. Use of seated elliptical, bike, treadmill. We obviously move into so many different ways that if a patient can't move it in a certain portion of their body, we can modify that and help another part of their body take over the work for them. Moderate levels of exertion, studying and understanding for those patients what that is exactly. And depending on those limitations, how we utilize sometimes an upper extremity bike versus a lower extremity bike, depending on where the active cancer is and where the surgeries and damage is. Just understanding that, sometimes patients can't go out for a walk, or they can't run like they used to. But teaching them how to use a row machine, ski ergs, we've got options. Resistance exercise has been studied, and using your body's weight against gravity without any weights, we can create significant load and muscle mass gain. The simplicity of us sending patients home with bands, tubing, showing them where they can order simple dumbbells, straps, et cetera. Understanding what a rate of perceived exertion is, and let them understand that there's a zone we're trying to keep you in. We're not trying to push your body to the point where you don't feel well. And if we do, then that's a learning moment, not a quit moment, right? If we push the body a little too hard and the body takes a little too long to recover from that, that's learning. We'll bring it back. It's not all or none, right? We can simply adjust. Just taking the fear out of it. All programs we start with are fairly light and progress to somewhat hard. And we have ways that we explain to those patients what that means. We only increase in small increments when it comes to load and repetition because the body can acclimate well if we stay within a low to moderate level of growth and improvement. We start most programs using 3 rounds of 10 repetitions, but I will tell you that is not where we're supposed to end in resistance. We'll teach you more about that. And so patients that are in treatment versus post-treatment are going to have different expectations. Obviously, less improvement was clearly recognized for patients that are in treatment versus patients who are post-care. But both groups show decreased fatigue and increased quality of life. And that's what we're trying to do. So it's, patients say, well, maybe I should, start to, and I get this all the time. When should I start physical therapy? Before you start cancer treatment. Right? I mean, these are the studies of actively while they're in treatment and after treatment. But the truth is where do you start beforehand? Go into that as in the best shape, in the best way you can. When you have a higher place to fall from, you're not going to fall as far low, right? And that happens for muscle, that happens for cardiopulmonary endurance, and we have to be able to educate on them. When we talked about the rehab protocols and rehab programs that we do for somebody getting ready for a knee replacement, and the prehab is so important, right? Why aren't we doing that for patients that are about to go through cancer care, right? It's got, the languages have got to be there, and the conversations have to start early, and it's got to be as meaningful and as important as everything else. I get the fact that this isn't going to be the thing that saves their life, but it's the thing that's going to optimize their life and have a life that's worth living. So that's why it is important. 10 general physical skills that are affected that we are dealing with right now to kind of understand some of the different pieces of complexity, but also how we got to put it all together, that it's not just a one-trick thing that we're dealing with, that if the person goes for a walk and they help improve their cardiopulmonary endurance, that's good enough. The effective issues, stamina, strength, flexibility, power, speed, coordination, accuracy, agility, balance. Does this sound like all the things we have to deal with an athlete, right? So these areas are more impacted on a patient that's dealing with cancer than on anyone else, any type of our patient population. Every single one of these categories is a part and piece of the evaluation and the treatment strategy to get them back to that previous quality of life. Metabolic pathways affected. Phosphagen, glycolytic, and oxidative pathways, one of the things to not make y'all all fall asleep on some of the science behind this, but patients really do not understand what it takes to get, say, strength back. We'll start with phosphagen, right? Strength and power happen under high load and resistance. That would scare any patient that doesn't understand exercise and movement. So I'm going to give you an example of the science behind it. In order for someone to start creating strength and power gains, so if you have a patient that's lost a tremendous percentage of their strength and power gains, when the brain starts to really react with the body, is taking a load that's so heavy that the body cannot do it 4 times correctly. 3 times maximum. To have that system scream to the body, you need to grow. So patients, a lot of times when they get back after they've been brought to their knees with this, they come back and they're like, okay, well, I'll start some strength training, and I'm going to do, like we talked about, 3 sets of 10. And I'm going to do this exercise that I can just comfortably do 10 times, and I can, everything's fine, right? And then they're like, I don't understand, but I'm not getting much stronger. Well, if I went to the gym and I took a dumbbell that I can comfortably, easily do, why would my bicep grow, right? this human body's pretty smart. It's like, you got this. You don't need me to change anything, right? But if you can create enough stress on the human body that the body can't do this easily, and it's struggling in the phosphagen system, it can't do 4 of them, the brain's gonna tell the body, it's time to grow. We gotta go. We gotta get thicker. We gotta get stronger. You're gonna see muscle hypertrophy. You're gonna see massive strength gains, right? So the difficulty in this game is that we have to start the patient somewhere that's comfortable and happy, and 3 sets of 10, and I started to practice again, right? But that's not where it ends. Just like with the athlete, we've got to get them back, and that back may be a pretty big distance from what they could do before to now. And so we have to structure programs that look at, if their endurance was massively effective, what are the best oxidative programs and plans that we put in place for that, right? Glycolytic programs, being able to stay under load for a brief period of time, but stay long enough to not overly fatigue, and the ability to really get to the point of being able to move big, massive load that the human body is going to then be triggered to grow from, all needs to be part of the discussion and the equation. And we definitely are going to do that in a very safe and effective way. So fear avoidance is the biggest issue that I seem to deal with on a day-to-day basis with patients. We talked about it from the fact that I opened up my conversation with patients who are afraid. We're going to continue that mode so that if I beat anything into anybody's head when it comes to cancer, it's we got to get patients out of fear, because fear avoidance is what kills them. Patients are afraid, they're confused, they don't know where to begin. We start by telling them the data. We tell them that exercise is safe and beneficial. We need providers to refer patients to physical therapy providers that are educated in cancer rehabilitation. The American Physical Therapy Association offers now in the specialty boards of orthopedics, neurology, pediatrics. It's amazing that now we actually have a complete specialty board just for cancer rehabilitation. The STAR program, survivorship, training, rehab, is all part of the processes of that new education. We do have the battles with insurance. We're not any different than any other service, sadly. We have private insurance companies that do not want to pay for patients that are not showing consistent signs of recovery, but they're getting rehab in the middle of being, radiated and suffering from some of the chemotherapies, right? And we're trying to educate them on the standards got to be different. You have to change the program. Insurance companies would like to pay for nothing new. And so it is a fight, but we won a monumental fight. And the American Physical Therapy Association, starting that fight with Medicare, the private insurance companies are now starting to follow suit. And that's a big deal. Medicare now pays for maintenance therapy. It does not require patients to make improvements, but it focuses on maintaining the highest level of function possible for a life-threatening illness. This is huge. This is major because, as we all know, once the federal government starts that and Medicare starts that, we can somehow get the private insurers to follow suit. The bad thing they did was we won that battle, but there's this little thing that we deal with Medicare called MIPS. And we got to show all this patient data that we're doing so wonderful with our patients, that we're staying in these high regulated areas, or you're going to get reduced payment from Medicare on all your patients the following year. Well, if you're looking at your MIPS data on your patients that you're treating with cancer, you're not going to get those patient outcomes. And now it's going to negatively affect the physical therapy practice when it comes to reimbursement the following year. So we still have issues that we're battling that are going to negatively impact why the therapy world hasn't completely absorbed all this yet. But I can tell you that we have some wonderful people and wonderful associations that are fighting that battle. Every program can be scaled to meet patients where they are. Patients do not have to fit a box of a certain type of exercise program. There'll be patients that come to me and they say, Troy, I love to dance, or I love to do Pilates, or I love to do yoga, but because of, where my port is, or because of what this is, I can't do that anymore. That's not true. We always can scale an activity and make modifications so that maybe you might change some things in a program, but we'll scale it to fit you. We'll meet you where you are. We'll start there. It's okay. There's always a way. So to complete this and finish on time, the National Comprehensive Cancer Network most recent guidelines for both cancer-related fatigue and survivorship recommend rehabilitation as an intervention for cancer survivors. Word's out. Movement's there. And just so that, if people are asking for specific references, I know this is, in small form. It was in case you can get the actual talks that I just put down numerous studies so you could show patients that the data is present, specific to that cancer or in general. The conversation can be had, and we can show them evidence that this is okay, this is safe, you can do this. So with this being said, I hope and pray that this has had some positive effect on someone's future conversations and discussions with patients that are struggling with cancer, and thanks for giving me y'all's time.